So home health care, it can be, if you're a Medicare eligible recipient, it can be Medicare, but it can always be private insurance. And then some agencies will do private pay too. You just kind of have to look at that and see if that fits, within your scope to be able to pay for things. So this entails a Medicare home health care service, but really it is for anybody that needs that skilled service. So much what Diane had talked about. You are considered homebound, so you're really not going out of your house except for maybe medical appointments, and you need skilled care such as that nursing, a physical therapist, occupational therapist, or speech therapist like Diane had talked about. It also has to be medically necessary, and your doctor is typically the one who's prescribing it for you. So they're writing out a prescription and recommending it. And some different examples of things that we would help with, are really looking at, maybe you're given a new medication. We can help you while monitoring you taking that new medication, looking at your new diagnosis, just helping you through that process and, the different changes that are going to be going on. If you had wounds, we'd help you with wound care, and just the exacerbation of your medical condition. So we know with ALS, you're constantly changing. So helping you understand that process, whether it's a slow process like we're learning today or a fast process. And then each therapies, and I don't have to read this verbatim for you, just looking at how can that physical therapy or occupational therapy help you in your day-to-day functioning. So, from getting dressed to brushing your teeth to eating, with that limited mobility that you have in your arms that you've described. There's a lot of different adaptive devices and techniques that the therapist can help you with. So those are what the skilled services entail. And I'm just going to scroll back. So it was Dave, right? Dave, and I'm going to say Doris. You guys have had experience with home care. Do you want to share a little bit how those skilled expertise helped you?
They came in because, you have no idea
what this is.
And so they came in, I think they were here about a month. And then we did exercises for a nurse came and was always here. And they were excellent. But my question is, can they come back?
They can, yes. So skilled home health care, it's made to be a short-term intermittent service. The easiest way I like to describe it is, things are going to constantly change. So if there's something new that you need to have assessed and your doctor says that it's okay to do that, they can definitely come back. Individuals can be on skilled home health care services for a month to 2 months, sometimes even longer, or it might even just be a shorter term, a couple of weeks, just to help with that education and training. So yes, skilled home health care can come back, and they can come back several different times for short-term intermittent training and support that's needed.
Do they have help?
You probably work with our La Crosse office. As far as I know, our La Crosse office does. I work out of our Eau Claire branch, and I can speak, for our branch, we are fully staffed. We have 9 nurses on staff out of our Eau Claire office, and we have 2 therapy partners that we work with. So we have our skilled nursing, physical therapy, occupational therapy, and speech services. What our Eau Claire office does not have is that home health aide. But for skilled home health care services, a home health aide is really only going to help if it's a skilled need. Whereas when Karen shares information, most people generally need a home health aide to come in and help with like bathing, cleaning, maybe grocery shopping kind of thing. And that's not considered a skilled need. So our home health aide would really be working in conjunction with that nurse and the therapist as far as a short-term help with that. And La Crosse, as far as I know, La Crosse is fairly staffed the same way, but I can certainly get that information from my counterpart that's in the area to see what their staffing is.
Yeah, thank you.
Yeah.
Go ahead. I'll just chime in to say that from a funding standpoint, because you're getting a doctor's order, it's just like they're writing a prescription, they're writing an order for you to get these skilled care services, and then it's covered by Medicare at the 80% and with your supplement and all of that. Unfortunately, it's very difficult to get Medicare to cover the supportive care that Karen will be talking about. And so again, oftentimes that will be more of an out-of-pocket cost. So
Yep.
just to kind of distinguish, and what I can say from my experience with ALS is that typically, except for a certain juncture. So maybe you've just had a PEG feeding tube placed, and so you're having some kind of wound care issues with that. You may get some, some prescribed home care services through that. Or if some people get a catheter placed, or maybe you're having some pressure wounds and there's some wound care issues. So those are typically the kind of things, or, again, with speech and swallowing, maybe doing some assessments to try to assist with, swallowing safety and things like that. So there are those junctures in the ALS journey where a skilled care comes into play, but more often than not, even if, as some of you have already described, it's just the need for the caregiver to get a break, to have somebody else kind of come and maybe assist with getting the person up in the morning or things like that.
Yeah. And I'll just share one more thing, because if you are Medicare eligible, home health care is covered at 100% by Medicare. So what they look at, though, just so that you can kind of see, so this is another handout that I'll send your way. So Medicare does pay for the skilled home healthcare services, as long as it's been prescribed by your physician and that it's needed for that medical reason. And then the other thing they look at is that you have to be homebound. And then these are kind of the criteria, and I have a separate form that elaborates more on the homebound status too. So really, you're at home. You're not going to leave really except for medical appointments. If you get your hair cut or something like that, it's okay. But when you go out to get your hair cut, it's very taxing for you, and you get very tired when you go out for an appointment like that. It's when you're going out frequently, taking a trip, all that kind of stuff, that you wouldn't be considered homebound. But in all of your instances, just on what you've described and shared, to me, you would be considered homebound, and that you would meet that Medicare eligibility for coverage and services. So this is what we look at. So it is 100% covered by Medicare, and it is a benefit to you to use, as you need it for that short-term intermittent teaching and training and education and support. And that's really, that's kind of that in a nutshell, and each person is an individual. So what your care plan would look like is really going to be catered to you. It's going to look different from one person to the next. But yeah, I hope that helps. Just know that it's a service that's out there for you, and it's available, and one nice thing in the Chippewa Valley. So for Eau Claire, Chippewa, and Dunn counties, we have 5 home health care providers in this area. And I know La Crosse has just as many home health care providers. So you have a lot of options. And if you are a Medicare recipient, Medicare has a nice little guide that talks about home health care. And I can attach that too, so that you have that as well, because it has some questions in it. So you can do your due diligence and kind of call each home health care agency and investigate them, find out what their staffing is, find out what their service area is, and then what all does their team help do and provide within that area, because each team is a little bit different. I know for the agencies that are in the Chippewa Valley right now, we're all about a week to a week and a half, sometimes 2 weeks out before we can actually admit a new person onto services, just because we're that busy with home health care referrals coming in. For us, we are currently caring for 126 patients right now throughout the Chippewa Valley. So we're very busy, and we just keep adding every day. But it's truly a good thing and a wonderful resource for you. So just know that you have that in your back pocket.
But I have called some of these home health, and they cannot take another patient on because the staff shortage.
Yep.
That's the problem down here in La Crosse area.
In that area. Yeah. And it is because they have, so like I can only speak for, Aveanna Home Health in the Eau Claire office. So each of our nurses typically will have 18 to 20 patients on their caseload. And that's what they're seeing within a week's time frame. So as our nurses discharge a patient from services, then they're picking up a new patient to fill in that caseload. So yeah, it is a very challenging thing not to have staff. And that's, I would say, everywhere. So for us, I'm going to just keep knocking on wood. We're very fortunate right now to have 9 nurses, because there are some other agencies that don't have that opportunity right now. Yeah.
Well, and I'll just share that, and I'm sure this, I would assume that everybody on this call has been approved for Medicare and is on Medicare regardless of your age, because ALS is automatically, it's one of the very few diagnoses that is automatically eligible for Medicare as of the date of diagnosis. So again, it's great to have, and so basically it's up to you to talk to your doctor to say, I could use some help with this, that, or the other thing, and then they need to write the order and get folks like Angela and her team on board. So anything else, Angela, before I hand it over to Karen?
No, I would say unless there's other questions, but I'll send out those resources, particularly the Medicare Home Health Guide, because it's very helpful. It also tells you what Medicare, as far as a skilled service, doesn't cover. And those are the services that Karen is actually going to talk about. And I've had the pleasure of knowing Karen for several years. So I'm going to turn it over to you, Karen.
Thank you. Thanks for having me.
Absolutely.
I'm Karen Herbison. I am the owner of Visiting Angels. My husband and I started this here in Eau Claire back in 2013. So we've been fortunate and honored to serve two clients that have had ALS. So it's not prevalent here, but we have been able to serve and assist. So what we do, like Angela said, is we are the supportive side. So we're non-medical living assistance services. So we come in, we can help you eat, we can cook, we can tidy up, we can do laundry, strip and make beds, run errands, help you with bathing, whether it's bedbound bathing, or helping you into the shower. So that's kind of what we do. Many times we are serving a client, but we're really serving the family so that when the family comes back, they can just be with the client and not have to do laundry and do dishes and clean up. So that's really what we do. Now, as far as Medicare and Medicaid, they don't take us because we're non-medical. You have to be medical in order for them to pay. Now, we have dealt with insurance companies. There is long-term care insurance riders that will pay or reimburse for our services. You just have to make sure that it's in the plan. We are private pay mostly. So we have had situations where the VA has paid as well. So if there's any veterans out there, then you might want to check on that too. But that's what we do.
Yep.
And how have you found it as far as having enough folks on your staff to provide the support that these folks need?
We would like to have like 10 more caregivers. That would be awesome. But that's not going to happen. Not in this environment, not right now, maybe after the summer. Depending on the level of need. So there may be a time where we would have to say that's more than we can do. Like we can't pick anybody up. We can assist. We can get them to a wheelchair. We can get them to the commode. We can get them to the bathroom, that sort of thing. But if we have to physically pick them up or use a Hoyer, then that goes to the medical side. So that would be where we would have to draw the line. As much as we'd like to,
What about something like assisting with tube feedings?
Tube feeding is a no for us. There has been a family that the daughter would run in and show us what to do and say, I got to go, and we would help. But for the most part, that would be a no.
Okay.
Because
and I know
that's
those
more
are some of
medical.
I think those are some of the challenges that some folks have experienced, is that some of the things that are kind of day to day, for them are kind of considered more intrusive or more high end in terms of supportive type of care.
Right.
So what question does anybody have in terms of, issues around getting help and getting health care or getting supportive care in your homes? Anyone?
I have a question. So the Angela, it doesn't go by county then?
For home health care?
Yes.
No, you should have a home health care provider within your area. I mean, probably even several, depending on where
I'm
you're
in
at.
the Cross area.
Yep.
But, and so through the Aging and Disability Resource Center in Viroqua, because we're in Vernon County,
Mhm.
I'd have to call that lady back again because too many facts for somebody who didn't know what I was even talking about. But she said something about they have nurses through the Aging and Disability. And I don't even know if there's a cost involved or, because I haven't had to use that.
Yeah,
So,
that it might be, similar to, I guess, Karen, as far as supportive. So I know that there are private duty nurses, which would be different from skilled home health care. And the Aging and Disability Resource Center would be able to give you a list of private duty nurses. And those private duty nurses would be able to help with, say, like those tube feedings, because they're skilled and trained in it, just like what Diane was talking about. So it's kind of, I don't know, I suppose that's in between. So if you think of skilled home health care, they're really like an extension after you leave the hospital for something, or maybe you visited your doctor at the clinic and you were given that new diagnosis. It's there to help you learn about what's going on currently with that new illness, change in your health. And then that private duty nurse would be someone to kind of fill in, still have a nurse expertise, but isn't underneath that skilled home healthcare benefit. And then you have Karen, which is that supportive home healthcare services, which really helps you with those other day-to-day things. I hope that helps explain things a little bit more.
and if I have to call Vernon County back, it's helped to have this discussion. So I'll kind of know the difference between, because they don't always explain all of that well, and they don't know what is out there either for us, depending on our special need.
Yeah, and I'm not, like Vernon County, they might have their own home health agency. I know for a time, Chippewa County and Dunn County had their own home health agency within the counties, but they dissolved them a few years ago. So then the other home health care providers help to take on those patients. And every county is a little bit different. I don't know that area, but your Aging and Disability Resource representative should be able to tell you if it is a home health care agency or if they just have access to those private duty nurses.
Karen, it looked like maybe you had something to add.
No, I was just in agreement. Yeah.
Excellent.
But I don't know what a person does. You can get help in your home because there's nobody out there to help you. You call these agencies, they can't take any more clients. You call a nursing home, you can't even get on a list because they aren't taking any people at all anymore. And so we feel sort of lost because we don't know what to do, because we do need the help, but we can't find it.
And you're not alone at all in that, Doris. And again, this is something, we're working more closely with other chapters around the country right now. And, again, we're finding this everywhere. And kind of to Angela's point about right now, her agency is doing well with being able to maintain the nursing staff that they have. But again, you get up to Rusk County, up by Patty and Jim out in the woods, or to some of these more remote counties, it's very difficult. And even sometimes when you get to the point of wanting to sign on with hospice, just getting, an agency that's available that has staff. And I guess I also want to kind of piggyback off of, I think, Angela, you were saying this, but really with both the skilled care and the supportive home care options, if you have more than one option, I really, really encourage you to, kind of think about what would be the perfect circumstance in terms of what hours the person would come in and how many hours they would come in and kind of what different types of support they would provide, and really kind of have some questions prepared and really do interview more than one care agency, because you want to be sure that you have the best fit. One question that I actually have, maybe more for Karen, is I've heard that for some people, they have found an agency that actually has some staff, but then they've been told that they can only get support from that agency if they can agree to a certain minimum number of hours. So, they can't just say, I want it 1 hour a day. It has to be a certain minimum number of hours. Can you speak to that?
Sure. For us, it's a 2-hour minimum. But that could be once a month. That doesn't, so there's not a, for us, for our agency, there's not a, you have to see us 3 times a week, 2 hours a visit. The other thing I did want to say too is, if I were to come and visit with any of you and you needed, just say 5 days a week. I know in our area, other agencies and myself team up. So for example, I may have somebody that could come Tuesdays, Thursdays, and Saturdays. But then another agency that does exactly the same thing I do has somebody that's available the middle of the week. So we let the client know, I can only do this. Let's partner with another agency. I'll give them a call. And we've done that, where we've shared the client just to support them. So there's nothing wrong with having a few.
Yeah, excellent. Well, I'm glad to realize you have that kind of collaboration and
Yeah.
again, in recognizing that, you know, the most important thing is the needs of the clients.
That's right.
Excellent. Any other questions either for Angela or Karen or for each other? I just want to kind of touch base. Audrey was saying, you know, I don't know how come, you know, after this number of years that I'm still, you know, doing as well as I am. And the truth is that ALS is just different for everyone. We do definitely see people that progress, you know, quite quickly. But we also have, you know, some folks that are in your situation, Audrey, where, you know, you just have more time and it's hard to predict. Obviously we have some of the treatments that are out there, none of which are, you know, ironclad, you know, proven to do whatever, but, you know, certainly some people are feeling that whether it's the Radicava infusions or the Riluzole medications or whatever that are helpful in some lengthening of progression. Any other questions?
I have one. I had made some notes when I had talked to the Aging and Disability. Tell me about, if any of you know about the spousal impoverishment program. What does that mean? Anybody?
I'm not seeing either of their Angela.
Well, I don't know that I could really, I mean, to me, it would be if you're applying for medical assistance or state of Wisconsin funding, then a benefit specialist from the Aging and Disability Resource Center could help you. I mean, if you enroll into that program, there's particular guidelines, but there's guidelines within that impoverished program to help prevent the state, for lack of better words, from like taking everything from you,
Yes.
if that makes sense.
Yes,
Okay.
I think you're exactly right. I think what it is you're a married couple and you or your husband can't deplete everything that you've worked for and leave you out on the street. That's kind of what it is. So it's a prevention, no matter what the ailment is, where maybe you keep your house, a car, you know, that kind of thing. So yeah, check into that.
Because right now we have to have a spend down. It's called a spend down,
Yep.
where we have to pay out of pocket until we get down to a certain level.
Yes. And
Right,
then
and
they'll
that-
cover it.
And then they'll cover it.
Yeah, and this whole issue, like Angela said about, you know, qualifying for medical assistance or Medicaid, family care, those programs are income and asset based. So as Doris was just saying, you know, if you get down below a certain threshold in terms of that, then you can qualify for those programs. But again, to speak to the spousal impoverishment, it's all about trying to make sure that somebody, you know, because of their significant healthcare issues and needs and expenses, that somebody, you know, that their spouse doesn't end up not having a home, not having, you know, a place to be. So that's, again, and we've had the ADRC come in and speak to those things, and I'm sure we will again. But those are definitely important programs to be aware of.
Yeah. And I would just, you know, to learn more, ask for the benefit specialist, because they have different representatives throughout the Aging and Disability Resource Center to help you with various things. So the benefit specialist will help guide and direct you towards all of that information. And then options counselor is another staff member that's within their team. And they're the ones who would help you with all the different resources. So for skilled home health care to supportive home health care to your durable medical equipment, that kind of thing. And your resource groups like what you're in right now.
Excellent. Anything else? I just want to mention that our next meeting is scheduled for 28 days from today, which is March 10th. And I don't have any speaker currently scheduled to present. One of the issues that we have encountered, especially right now, just sort of clustered in central Wisconsin, is situations where someone, and I'm glad we've been speaking to the non-invasive ventilation issue and, to just kind of helping your breathing along and so forth. We've had some situations where due to emergencies that people have had, they've gotten hospitalized, and whether it was COVID-based, whether it was somebody just getting pneumonia from an infection, whether it was, other kinds of emergencies, have ended up in the hospital and then getting basically a tracheostomy done and put on a ventilator. And, that's a really, really difficult situation and not a decision that you ever want to make in an emergency because you're not going to get great guidance. So what I want to do next month is just really have a meeting where mostly we just kind of check in with each other and share stories and share, experiences. And I'll give you a little bit of guidance on what I'm hoping to talk about with that. But we'll also spend a little bit of time talking about preparing for that situation and being sure that you know what that's involves and know kind of how you would handle it if you were in the unfortunate situation where you landed in the ER because of some respiratory issues and then had to make some decisions and kind of how that can play out. Because you want to definitely be in the driver's seat with that. So I think we'll plan to talk about that because I do think it's really important. And does anybody have any final questions? Angie, you can probably stop the recording now. Any other following questions either for